Assalamu alaikum. Good morning for everyone. First of all, I would like to thank Dr. Khalid Suefi and Dr. Amr Abul Aila for the great idea of the COVID-19 course and for inviting me to participate in such a great event. Today, I'm gonna talk about APRV or Airway Pressure Release Ventilation. Airway Pressure Release Ventilation is a mode of mechanical ventilation which has generated a lot of debate. Maybe because the literature did not mention or address and answer the question, the question about the APRV, if APRV is the mode which can be initiated in a patient with ARDS or not. The purpose of the lecture to make you more confident about the use of APRV mode, to know the evidence behind APRV recommendations, to help you recognize the indications for the use of APRV, to know how to set and how to wean patient on APRV mode, and to know if APRV can help in the management of COVID-19 patients or not. Before starting the lecture, let me to remind you by the pressure volume or volume pressure curve, and here you can see the lower inflection point. Below it, the alveoli is collapsed, and above you can see the upper inflection point, and after it the alveoli is overdistended. If you compare the APRV conventional mode of mechanical ventilation volume controlled, you can see here that the APRV guarantee ventilation of the lung within the steeping portion of the curve between the lower inflection point and the upper inflection point. So it may help to avoid lung or alveolar collapse and alveolar overdistension. So APRV may be suitable for the pathophysiology of the ARDS patient and help us to avoid the main drawbacks of conventional mechanical ventilation. What is the main drawbacks? While you are doing recruitment of the unhealthy alveoli, you can cause overdistension of the healthy alveoli. The airway pressure release ventilation actually is not a new mode. It's first described in 1987 by Stock and Down, defined as continuous positive airway pressure. You can say that the APRV is a CPAP with intermittent brief release. And the current understanding of the optimal strategy to minimize ventilator-induced lung injury is to open the lung and keep it open. So, APRV should be ideal for this strategy with the prolonged CPAP duration, recruiting the lung over a long time, and the minimal release duration to prevent the lung from collapse. Regarding the evidence behind APRV, all original articles in which the authors stated that APRV was used, almost none of the APRV settings were identical. Previously, how to set the APRV, it may be fixed APRV set in which the release phase is set and left constant, or personalized APRV in which the release time is set based on the lung mechanics. But no study was there a statistically significant worse outcome with APRV. Most of the studies giving a positive result regarding improvement of oxygenation, but no studies showing harm or negative feedback about the APRV. Over the 30 years since the mode's inception, there have been no strict criteria in defining a mechanical press as being APRV. But B or personalized APRV has shown great promise as a highly lung protective ventilation strategy. Here, one study published in 2017 about early application of airway pressure release ventilation may reduce the duration of mechanical ventilation in acute respiratory distress syndrome. This study randomized around 138 patients. 71 patients were assigned to receive the APRV protocol. 67 patients were assigned to receive the low tidal volume protocol. Here, you can see that if you compare the APRV with the low tidal volume protocol, I can say here that the plateau pressure is less with APRV with significant p-value. Respiratory compliance is better with APRV with significant p-value. The mean airway pressure and the oxygenation with its hypoxic index or PF ratio is better with the APRV with significant p-value. Not only that, but also the RAS score, which is the most validated score to assess the patient's sedation. We find here that with APRV, we require minimal sedation, and it's almost around the -2 RAS score, which led us to avoid using tons of sedation to keep our patient knocked down, or even using muscle relaxant with low tidal volume protocol. One of the advantage and the beauty of the APRV that we need our patient to be awake and to breathe spontaneously all over the cycle. So, compared to APRV with low tidal volume protocol, early application of APRV in patients with ARDS improved oxygenation, compliance, decreased the plateau, and reduced the duration of both mechanical ventilation and ICU stay. Another study published by Canadian Agency for Drug and Technologies in Health in 2018 about airway pressure release ventilation for acute respiratory distress syndrome as a clinical effectiveness and the guidelines. This study includes 2 randomized controlled trials and 3 non-randomized studies were identified regarding the clinical effectiveness of APRV in adult patients at risk of or with ARDS. What is the result? 3 studies were favorable to the use of APRV in patients with ARDS. 1 study was favorable to the use of APRV in patients who were at high risk of developing ARDS. And to be honest, while I am searching in the literature to prepare the lecture, I found that about 25% from the patient admitted to the ICU without ARDS, they can develop ARDS after or within 48 hours from connection to the mechanical ventilation. Another study reported that APRV was a useful ventilation strategy in critically ill morbidly obese surgical patients with already compromised lung function. So most of the study up till now it is positive result toward APRV. Maybe in January 2020, few months ago, another meta-analysis and systematic review just published about the safety and the efficacy of airway pressure release ventilation in acute respiratory distress syndrome patients. This including around 14 studies, include about 2,096 patients, comparing the mortality between the APRV versus low tidal volume here above and lower between the APRV versus synchronized intermittent mandatory ventilation. You can say here that there is no significant difference. Again, they are here comparing the duration of intensive care unit stay between APRV low tidal volume versus low tidal volume above and down between APRV versus synchronized intermittent mandatory ventilation. Again, you can observe here that there is no significant difference. But the average increase of PF ratio was about 75% in APRV group versus 44% in the non-APRV group with significant p-value. So there is no significant difference we found in mortality and duration of ICU stay between APRV versus low tidal volume and APRV versus SIMV. So the main positive result here in this study that the APRV is toward improved PF ratio with significant difference if you compare APRV with low tidal volume protocol. So what can I say here? I can say that APRV from the studies I mentioned can improve oxygenation, and no study address any harm from using this mode, especially if you're gonna use it early in COVID-19 patient developing ARDS. What is the indication of APRV mode? Primarily used as an alternative ventilation technique in patients with acute lung injury and ARDS. Lung protective strategy to help protect against ventilator-induced lung injury. So in patient at risk to develop acute lung injury, better to start with that mode. Infrequently used by clinician for a patient with COPD. So it is not contraindicated to start this mode in a COPD patient. But if you're gonna use this mode, you have in COPD patient, you have to monitor closely your patient with CO2 frequent EPGs to avoid any retention of CO2. Post-surgery with high risk of atelectasis also as an indication for APRV mode. Definition of the APRV. APRV is classified as a time-triggered, pressure-limited, time-cycled mode of ventilation which allows for unrestricted spontaneous breathing throughout the entire ventilatory cycle. As we mentioned before, I can say that APRV is a CPAP for a long time with intermittent, very brief release phase. CPAP for a long time allow recruitment of the alveoli for about more than 90 to 95% of the cycle. You can recruit the lung because the CPAP time is a very long. With intermittent release phase help to rid of CO2, and this short time prevent de-recruitment of the alveoli. Bivent or APRV is the same. Provide two levels of CPAP and PEEP, which we can say B high and B low. The upper CPAP or the B high provides a moderately high level of pressure, and I will describe how to adjust the B high and how to adjust or set the B low. The B high also increases the mean airway pressure and augment oxygenation. APRV allows a brief release of pressure to a lower PEEP or CPAP, which allow exhalation or elimination of CO2 as I mentioned earlier, and the release time is short to prevent the peak expiratory flow from returning to baseline, which limit de-recruitment. Here, it is a very important point. The release time is very short. It does mean that I am not allowing the flow to reach to the baseline or zero. It means I am creating an auto PEEP. So this auto PEEP, it may improve oxygenation as well. So I am here creating auto PEEP by time, not by pressure. What I mean by time? By the release time. When I set the release time very short, so I am creating here auto PEEP, which may help to improve oxygenation. The benefits of this APRV for facilitation of spontaneous breathing. Of course, here when I'm using the APRV, I need my patient to be awake so he can breathe spontaneously all over the cycle. Increased patient comfort. If the patient breathes spontaneously, it is the best option to keep ventilator patient synchrony. and decrease sedation because I need my patient awake. Elimination of neuromuscular blockers to can avoid even the side effect of the neuromuscular blockers. Increase hemodynamic performance and avoid even the side effect of the sedation and the hemodynamic compromisation. Decreased the peak inspiratory pressure for any given mean airway pressure. Increased recruitment and limited de-recruitment as we mentioned earlier because most of the cycle is CPAP, so I am giving pressure all over the cycle about more than 95 or 90 to 95%, and even the short release time to avoid or to limit the de-recruitment. What is the benefit? Again, and here's the mechanism of the function of the bivent or APRV. Lung recruitment over time. With recruiting the lung, I am creating collateral channels for ventilation. Mean airway pressure, which is augment oxygenation as well. Facilitation of spontaneous effort. Allow synchrony with the ventilator. Improving VQ matching. Time constant as T high or time high and time low or time beep, and I will describe soon each. Maintain functional residual capacity above closing capacity on expiration and avoid de-recruitment of the alveoli. What parameter I have to set while I am using APRV mode? B high, B low or beep, T high or time high, time low or time beep, oxygen concentration as same like any conventional mode of mechanical ventilation, inspiratory time rise. This is the time needed for the preset pressure to reach its maximum. Usually you are set around 5 to 20% from the cycle. Usually around 0.15 seconds. This is usually we are setting around. Triggering, shift low or pressure, whatever. Inspiratory cycle off. This is the cycling or change of the cycle or the gas flow from inspiration to expiration, which is around 40 to 50%. And the pressure support above B high, pressure support above B or B low. All parameters are set independently of one another. Here there is a screenshot from the servo eye ventilator, the ventilator we are using in our unit, and showing you which parameter you have to set from the B high here. This is the B high and this is the beep or B low oxygen concentration, T high, T beep or T low, and T rise time 0.15, triggering flow, and here inspiratory cycle off, pressure support above B high, pressure support above beep or B low. Again, here there is a screenshot from the wave, from the waveforms. Here's the pressure, flow, and the volume. And this is also servo eye ventilator, the ventilator we are using in our units. Here you can see the B high is around 30. Here's the T high from the end of the previous cycle to the beginning of the second cycle, set around 5.5 seconds. B low set 0, and the T beep or T low set 0.8 seconds. How to set B high? B high or pressure high I can set simply if the patient before starting APRV was on volume controlled mode. I can set the B high the same value of the plateau pressure on the previous volume controlled mode. What about if the patient is on pressure controlled? I can set the same like previous peak inspiratory pressure, because the peak inspiratory pressure almost near of the plateau pressure in pressure controlled mode. And the B high establish the upper pressure level and should be at or above the patient functional residual capacity. Patient can breathe spontaneously at this level at any time, as we mentioned earlier. Too high B high will overdistend the lung due to increased in volume. That's you have to take care to adjust the B high, because if you adjust high B high, it means you can overdistend the alveoli and you may lose one of the advantage of the APRV, as we mentioned earlier, that the APRV ventilates the lung within the steeping portion of the pressure volume curve. P high is relative to mean airway pressure, and of course it affects oxygenation and augment oxygenation. Watch inhaled and exhaled tidal volume. As recruitment takes place, the tidal volume moved by spontaneous breath will increase. Here you can observe that the P high is set as a 30 centimeter water, and if you can see here on the right lower, the exhaled tidal volume is around 618, which does mean that the lung started to recruit it and the exhaled tidal volume increased up to 618 cc. What about the T high? The T high usually initially we can set the T high from 4 seconds or 4.5 up to 6 seconds. T high is the inspiratory phase for the ventilator controlled breath. The shorter the T high, the more releases, which increases respiratory rate. Of course, if this is opposite way, we have a total cycle is including T high and T low. If the T high is short, it means the T low is long and more releases and more rate of CO2. The more releases, the more you decrease PCO2 and vice versa, as we mentioned. And the patient is able to breathe spontaneously between the releases, of course. Here, a screenshot from the monitor, and I can see the T high here is set 5.5 seconds. Why not? I am setting a beep. I can set the beep here or below at a 1 to 2 centimeter water, but better to avoid set beep above 0 because you are increase the resistance against during expiration. If the patient expire against the beep, it means you are increasing the resistance, which may add to CO2 retention, which may increase the CO2 in such a type of mode of ventilation, APRV. Here, a screenshot to show you the T low or the beep here set as a 0 centimeter water. T low or T beep here, I will tell you later how to set actually. Usually initially from 0.5 to 0.8 second, but there is a method how to set it. I will tell you soon within second how to set the T low. The expiratory time should be short enough to prevent de-recruitment, as we mentioned, and long enough to obtain suitable tidal volume. If the tidal volume is inadequate, the expiratory time is lengthened. And if it is too high, more than 6, the expiratory time is shortened. When increased T low, if I increase the T low, it decreases the intrinsic PEEP and vice versa, as we mentioned before. When I'm increase, I decrease. I am creating auto PEEP by short T low. And if the T low is very short, I am creating auto PEEP. I will tell you here. I will show you here's a screenshot again showing the T low or beep, T beep, time low or time beep is around 0.8 seconds here. T high plus T low or T beep is equal the total cycle time. Agree? Agree. And give you the IA ratio. In such mode, APRV mode or bivent mode, how can I calculate the respiratory rate? You can calculate here the respiratory rate. I will show you soon one slide, but you can calculate by 60. You can calculate 60, which is minutes in some number of seconds in a minute, divided by the total cycle, T high plus T low. The clinician should note that through manipulation of the T high and T low combination, extreme range in total respiratory rate are possible. You can see that I set already the T high is 9 seconds, T low is 0.8 seconds, so the total cycle is 9.8. Agree? Yes. So how can I calculate? I can divide 60 divided by 9.8, it will give you 6 breaths per minute. as here the ventilators give you that this patient taking 6 breaths per minute. So you can calculate it as well. What about the pressure support above B high and above B low or PEEP? The level of pressure support may be added to augment the patient's spontaneous tidal volume at either B high or PEEP. So I can, in such APRV mode or bi-vent mode, I can add pressure support to the B high or pressure support to the B low. As the patient may be or near their inspiratory capacity and extra pressure may cause overdistension of the lung. But you have to take care. If you're gonna add pressure support during B high, you may cause overdistension of the alveoli. What about if I obliged to start pressure support or pressure support above the B high? You can here see this example. The patient here set without pressure support. Here the pressure support is 0, you can see. And here the pressure support start to set 6. If you're gonna start the pressure support, for example 6 for the patient, so you can decrease the B high by half of the value of the 6. So I can decrease the B high by 3, half of 6. So I put the B high is here 27. So I can avoid overdistension of the alveoli. But usually, as an initial set, we are not putting pressure support. We are putting pressure support 0. Here is example to show you that the pressure support above B high is 10, and here again pressure support above PEEP is 0. Screenshot to show you the time rise. Here set as a 0.15, and as I said before, in the time rise we are setting the time rise. This is the time needed for the preset pressure to reach the maximum, and almost is around from 5 to 20% from the cycle, and here is around 5%, which is around 0.15 seconds. And here this is inspiratory cycle off. Usually we are set about 40 to 50%. So here just as an initial setup of the APRV or bi-vent. So tell me please, try to interact with me that what is the initial setting to put in such patient with if I decided to put my patient on the APRV mode. The B high, how much you gonna start with? As we mentioned, if the patient previously was the same like plateau, if patient on volume controlled, if the patient was on pressure controlled as the peak inspiratory pressure. T high, how much please? Yes, we are starting from 4 or 4.5 to 6 seconds. PEEP or T or B low? Yes, 0 centimeter water. T low, as we mentioned, from 0.5 to 0.8, but to be more accurate, because the T low is very important parameter to set. How I set? I set by two methods. Number one, equal to time constant, or to keep or adjust the T low by the expiratory flow. To achieve, I can make the end expiratory flow around 50 to 75% from the peak expiratory flow. I will show how can I calculate or give you the result of the time constant. Time constant is the time needed to empty around 63% from the lung. And the time constant I can calculate or can give the result by expiratory hold, and you see here static compliance. The resistance is equal to the time constant. So the time constant is equal to static compliance times resistance, which here you can see 0.78 or almost around 0.79. This is the time constant. So initially I can set T low as equal to one time constant, it means 0.79. Or I can set, if here you can see here, this is the peak expiratory flow, and here's the end expiratory flow. I can set the T low according to the end expiratory flow. So the end expiratory flow should be from 50 to 70 expiratory flow. Here, screenshot can show, if here I set the TB, or T low, 0.8 second. So if you can see here, the total beep is 9. Is it right? Total beep here, this is the intrinsic beep, because I didn't set extrinsic beep here. We mentioned that the beep here is 0. So the total beep here, it means intrinsic beep. I'm creating a beep by brief release phase. So what about is the beep to 0.6? So you can see here that you increase the total beep to 12. So it is vice versa. If I decrease the T low, I increase the total beep. What about how to treat the troubleshooting of the APRV mode? If the patient develops hypoxia, to increase PO2, what can I do? I increase the B high in 1 to 2 centimeter increments. This is number one of the option. Or shorten the T beep as we mentioned. If you shorten the T beep, you are increasing the intrinsic beep and improve oxygenation. And increase the T high from 0.5 to 1 second. Also, which may encounter a slight increase in CO2. And the last resort, you can increase the B low by 1 to 2 centimeter water. And better to avoid playing with the B low to avoid de-recruitment of the alveoli, please. What about if the patient develops CO2 narcosis, or I mean CO2 retention? If the patient is not breathing spontaneously, wean sedation to encourage the patient to breathe spontaneously. Increase B high by 1 to 2 centimeter water. And T high manipulation here, if you manipulate the T high, it is a double-edged sword. What I mean? I mean, if you increase the T high, you may improve recruitment and improve CO2 clearance. And if you reduce the T high, will increase the frequency of releases and increase the minute ventilation and improve CO2 clearance. Which of which? I will increase the T high or reduce the T high? I believe that you need to try, and maybe you make error, and maybe at the end you will find the solution or the best option to adjust the CO2 removal. So you can try initially to increase the T high and observe your patient and see the CO2. If not, you have to try the reduce the T high. Again, to decrease the CO2, if the patient develop high CO2, you can decrease the B low by 1 to 2 centimeter water, and the last resort may increase the T low by 0.5 to 0.1 second, but take care because it may cause de-recruitment of the alveoli. What about if the CO2 is low, hypocapnia? It may indicate that the patient is ready for weaning, I mean. So what can I do? I can decrease the B low, or the B high, sorry. I can decrease the B high if able from oxygenation standpoint, or increase the T high and decrease the T low. What about the management of the setting? Again, expiratory tidal volume during pressure release. Optimal volume might be around 6 to 8 ml or cc per kg, or ideal body weight. The undesirable, it is not good to have volume more than 8 cc per kg or the ideal body weight. So it may be caused by lung overdistension, which is we need to decrease the B high at that moment as a solution to decrease the overdistension, or may be caused by alveolar de-recruitment during the release phase. So I have to reduce the T low to improve this. Patient effort. Ideally, patient should breathe spontaneously over APRV. This is best without dyspnea. In patient with severe ARDS, the patient perform around 10 to 30% of the total minute ventilation. In mild to moderate ARDS, ideally, patient perform 30 to 60% of the total minute ventilation. If patient is not performing enough, what does it mean? We'll consider weaning sedation if over-sedated. It means maybe the patient over-sedated. Or consider weaning support level if there is support. Or I can reduce the B high and increase the T high. This is one of the weaning parameters I will show you soon. If patient is performing too much effort, so I will consider adding sedation if patient is anxious or agitated, and don't please ignore the pain. If the patient is in pain, I may add ketamine for my patient. Consider increasing support level, increasing B high and reducing T high if concerned that the patient may fatigue. Here it is the expiratory flow deceleration angle, which is normally around 45 degrees in normal patient. But what does it mean, the low angle? It means or it reflects de-recruitment or restriction as in patient with ARDS and abdominal compartmental syndrome. What high angle or flat angle mean? It reflects over distension or obstruction as in bronchospasm. But you have to know that changes in the angle may be more useful than the absolute value. It does mean that for example, sudden increase in angle could give me clue about acute airway obstruction. So you have to take the angle as a baseline and take care from any change if the angle will become more acute or more flat. Readiness for weaning. Patients should be spontaneously breathing at a reasonable rate, from 10 up to 25 breaths per minute. And your goal in the weaning, you need your patient to be awake but calm and quiet. Anxiolysis, consider adding dexmedetomidine or Presidex while weaning down propofol, or you can use combination from the propofol and dexmedetomidine. Pain control, consider adding a ketamine infusion to allow weaning down opioids. This is a readiness for weaning. If the T high is fairly long, reach around 8 to 10 seconds, FI2 50% or lower, below of 0, not significantly hypercapnic, ready to assume more of the work of the breathing, and not in severe shock. At this moment, I can say my patient is ready for weaning. Remember this word, please. During weaning, you need to drop and stretch. What to drop and what to stretch? I need to drop the B high by 2 or 1 to 2 centimeter and stretch the T high by 0.5 to 1 second. But drop and stretch, please. Don't forget this word. Maybe you have to do this every 4 to 8 hours as tolerated, and monitor for any desaturation, increased work of breathing, or tachypnea. When I have to disconnect my patient from the mechanical ventilation, once you reach B high of 16 centimeter water and stretch the T high to 10 seconds, the patient is doing nearly all the work of breathing and you are very close to being on CPAP. At this point, you can rapidly wean setting to CPAP at 15, maybe over 6 to 8 hours, and make sure that the automatic tube compensation is on. Patient may be extubated directly from CPAP of 10 to 15 centimeter water. But if you disconnect the patient from the CPAP, please, you can connect your patient to non-invasive ventilation or high-flow nasal cannula for at least 24 hours to avoid de-recruitment of the alveoli. You can imagine that you are putting patient of APRV and you are recruiting the alveoli most of the time and suddenly you disconnect the patient. So the risk of de-recruitment is very high, which may lead to failure and re-intubation again. So if you're gonna wean the patient from the APRV, you should use BiPAP or non-invasive ventilation or high-flow nasal cannula if you have for at least 24. Here there is a screenshot showing you the spontaneous breathing during the weaning trial. Here we are dropping the B high and we are stretching the T high. Here if you can see the T high here is around 15, so the patient is ready for weaning. I know most of you are waiting the end, and I promise the end is near. This is Dr. Josh Farkas, one of the assistant professor in Vermont University in USA. He said clearly his opinion in APRV mode while he is treating COVID-19 patient. What he said? He said we have had considerable success with APRV in our COVID patient, which is good news. Allowed us to support and extubate several patients successfully while avoiding paralysis, proning, deep sedation, inhaled pulmonary vasodilators, or ECMO. Patient typically can be weaned from 100% FiO2 to 50% FiO2 on APRV within 6 to 12 hours as they slowly recruit. APRV may be an economical mode. Economical mode because if you start APRV, it does mean less sedation, no muscle relaxant or at least less muscle relaxant, and even no proning position. And the proning, you can imagine if you're gonna prone the patient, you need at least from 4 to 6 persons, and all persons will wear PPE, and all of this is cost. So it also be economical mode, you can say that. Opinion regarding the APRV. Early APRV could be very useful for this patient, I mean COVID-19 patient, if used as the initial ventilator mode rather than a salvage mode. You have to use it early, please. APRV may be well suited to the pathophysiology of COVID-19 patient because it provides a high mean airway pressure and facilitates secretion clearance. APRV initiation can cause hemodynamic shift, so please, you have to pay attention if you start APRV for the hemodynamics. True failure to respond to APRV within 12 to 24 hours with PF ratio less than 100 to 150 would be a strong argument to move toward prone ventilation. Here there is a pathway. We implement this pathway in our unit, and I will consider this pathway as a take-home message for my lecture. Prior to start ventilation, or APRV I mean, obtain baseline, APG, and arterial line insertion is recommended. An inline suction catheter must be used. Enhance spontaneous breath by tapering down sedation and paralysis while maintaining adequate pain management. Set the parameter P high in volume controlled mode, same like plateau. In pressure controlled mode, same like pressure control, or you can see peak inspiratory pressure. T high, 5 to 6 seconds, spontaneously breathe and accepted PCO2. And you can set less, like 3 to 4 seconds if there is no spontaneous breath or unaccepted PCO2 high. B low or PEEP set as 0, as we mentioned. T low 0.5 to 0.8, and you can change according to the PF ratio. And as we mentioned initially, you can set as one-time constant or as peak end expiratory flow is 50 to 70% from the peak expiratory flow. If the patient PF ratio is from 150 to 200, you can adjust 4 to 6 centimeter water. And if patient from 100 to 150, adjust 7 to 8 centimeter water. Pressure support set 0 initially, as we mentioned, and FiO2 is 100%. So here, how to manage the troubleshooting. If poor oxygenation, increase either P high or T high or both to increase the mean airway pressure. What about poor ventilation and CO2 retention? Increase B high, decrease T high to increase minute ventilation or increase the T-PEEP or T-low by 0.05, 0.1 second, or decrease sedation, allows the patient to breathe spontaneously more. Weaning, don't forget drop and stretch. Wean FiO2 to less than 50%, decrease P high by 2 cm water per time as tolerated up to, we mentioned about, you can say 14 to 16, okay. Increase T high by 1 to 2 seconds per time as tolerated to 10 seconds. And if T high is more than 10 seconds and B high is less than or equal 16 centimeter water, you can change to pressure supported ventilation, and after that you can wean the patient to non-invasive ventilation or high flow nasal cannula. This is our protocol even regarding the APRV in our unit, including all the details I mentioned in my lecture. So here I reach the end of my lecture. I can say here the perfect is the enemy of the good. So it is not mandatory to be perfect to be good. But if you need to be good, you have to be perfect, I mean. So the APRV is a good mode to start with in patient with ARDS, especially during this COVID-19 crisis. And I believe that still we need randomized control trials to prove and to address and to answer the question clearly that the APRV is the mode of choice to start with in patient with ARDS. Thank you all and good luck.